You spoke to single agers, and this is something that is becoming more and more and more important for a variety of reasons. Not only are the people that are single in their own right, women are outliving men in the country by an average of 5.8 years when they're married. Aging demographics, 10,000 people every day turn 65. What are some of the common challenges or barriers that single agers and others are facing when they're trying to start these conversations, and what can they do to overcome them?
Some of it is giving permission to folks to think outside of the tradition of spouse or child, and that there could be a friend. I remember speaking at an event and a woman came up to me and she's like, my husband died recently. We didn't have children. I have a niece who lives on the other side of the country I'm not super close with, who I've chosen, but my neighbor is one of my best friends. Like, we go on a cruise together every year and I really trust her judgment. Are you saying that I can choose? It doesn't have to be family, and I can choose this other person who I might be close to in life?
This is the Buried in Work podcast, where we share tips and interview experts to help you simplify estate planning and end-of-life tasks.
Welcome to the Buried in Work podcast. I'm your host, Adam Zuckerman, and today we are absolutely honored to have Kate DeBartolo with us. Kate is the Senior Director at the Institute for Healthcare Improvement, though she leads a very special project, which is called the Conversation Project, an initiative dedicated to helping people discuss and document their end-of-life care wishes. Kate, thank you for joining us today.
Thank you for having me.
Yeah, so let's get started. What is the Conversation Project and how does it relate back to the larger organization?
Yeah, so the Conversation Project is a big kind of public health initiative, if you will, messaging, trying to help people have conversations about the care they would want through the end of their life and express those wishes, have people listen to them, make sure those wishes are respected. We live within IHI, or the Institute for Healthcare Improvement, which is a big kind of global nonprofit in the health improvement space. But this is a unique initiative within IHI that's meant to be more direct to people, not to health institutions only, to help make sure people's wishes, we're really focused on the care people would have before the end of their life or through the end of their life. And we know that both for individuals, for their caregivers, the people who love them, that's a really important thing. And for the healthcare system, that there is a lot of moral injury to providers when they feel like they don't know if they're doing the right thing for somebody. So we really saw it being beneficial from both sides. And that's how we got started.
So is this an initiative that's been around for several years, for decades? How long has it been operating?
Yeah. IHI has been around for over 30 years. The Conversation Project's more like 12 or 13 years. It was founded by Ellen Goodman, who is a Pulitzer Prize-winning columnist from the Boston Globe, based on her personal experience. This is where the idea came from. It was her experience caring for her mother and realizing that they had talked about, if I quote her, like everything under the sun. Like they had talked about absolutely everything except for what her mom wanted at the end of her life. And there became a time where her mom couldn't speak for herself. And the doctors were asking Ellen, what would she want? And she's like, I've got no idea. How did we not ever discuss this? And when she talked about it with peers and friends, there really seemed to be a difference between the experience for those who had talked about it beforehand and how like they were able to grieve the loss of their person, but not have as complex grief or complicated sibling dynamics or questioning whether or not they made the right choice. She brought it to IHI, and what was supposed to be like a 30-minute meeting went on for hours. And IHI really loved the idea of it and said, yes, like we'll house this project, we'll help you get it off the ground. And it started as its own 501c3 nonprofit, kind of incubated within IHI, and it's now we've dissolved that status. It's just an initiative of IHI.
How has it evolved over time? So it started as the 501c3, has the
Yeah.
scope, the scale, the deliverables, the mission. What's different?
Yeah. So, Ellen's background, especially from the Boston Globe, traditional media access. And the idea was, can we get people to write about this, talk about it on ABC News, that kind of delivery vehicle, and have a website. I should mention what we do is we try to provide free resources for people to help them have conversations. That's our goal. And to think about who might I want to choose to be a healthcare proxy, or what do I do if I'm a caregiver of somebody with dementia? Like, how do I talk about these things? So we originally thought, let's focus on traditional media, have a website where people can go. And very quickly, different community groups started to come to us to say, can we do this in Boulder, Colorado? Can I bring this to Barrington, Illinois? Like the local, sometimes it was Nancy Nurse, the retired ICU nurse, who said, I saw this my entire career. I want my encore career to be focused on this, and I can do education in my community. Sometimes it was state hospital associations or congregations. But so we quickly evolved to help a lot of those community groups who are reaching people where they live, work, pray, learn, to help normalize. So for us, it's not only to have tools for somebody in the moment, but also how can we normalize these conversations so people see it as something that we can all do. We don't need to wait for a lawyer or a doctor to bring it up with us. This can really happen. We say, we want these conversations to happen around the kitchen table, not in the ICU, because we know that a crisis is a really hard time to learn. So whatever we've been trying to find different ways to reach people early so that they realize this is something they can do. And I say kitchen table, realizing that's it has some cultural assumptions around it. For some people, their comfortable place or where they would talk to people might be different.
At the house, on a walk, anywhere that family is. Yep. Now, there's something that we talk about every once in a while called the mattress phenomenon. And it's not really a phenomenon. It's almost a made up idea that there are mattress advertisements all the time on the radio, on television, and magazines, but you don't pay attention to them until you actually need them. And when you need a mattress, suddenly you see it all over the place.
Yeah.
Is this something that you guys are struggling with too? And we've seen this in other verticals and other companies that are in the space where people need a new mattress, as the analogy or the metaphor, but until they actually need it, they're not looking for it. So how are you getting these conversations in front of people and helping educate people, this is something you should do? Because if it's out of sight, out of mind, at the time when they actually need it, it's the most challenging time for them to put things in place.
There's some work that we've done with some financial institutions where they found that this topic is always on people's top 5 things that they know they should do, but sometimes it's hard to get it out of that spot. So there's going to be something always more pressing on your weekend to-do list or your financial planning or, mortgage or kids going to college or marriage or divorce. So, there's some other things that kind of take priority there sometimes. We've definitely seen a shift in helping normalize this. COVID certainly brought that out for people. And yet we want to be careful. For us, we don't want this to only happen in a crisis or for people to think you only do this when you're really old or you're really sick. And COVID in some ways reiterated that. But we have seen so many young people be interested in this topic and really be open to it. High school students, college students, people who say, I love mountain biking, and I realize that's inherently risky, and maybe I should have a plan. Parents who realize they're not an automatic decision maker for their kids after they turn 18 or they move away. And so it's been interesting to find messengers who can help introduce this concept for people to realize this is kind of part of regular adult life, something that you can do. I also think that the baby boomer generation, as they've never taken things sitting down, and there's a lot of aspects of healthcare that have been affected by the baby boomer generation. And if I were to think of the opposite end of the life spectrum around birth and the birthing movement, that it was not clinicians saying, ladies, legs out of the stirrups into the bathtub, dad, come on in with the camcorder. It was people saying, this is a human experience, this is a life experience, this is not just a medical experience. And I want to have a say. I know when I had a kid, you're invited to create a birth plan of what, things may look different medically for each person, but can you tell us what would matter to you, how you would want this to go? Well, we're going to try to get the entire medical team on board with that. There's been movement towards that. And I think especially the baby boomer generation who really helped herald that with birth is seeing what's gone on with their parents or with peers and friends and realizing, wait a minute, I can get ahead of this. I have opinions. I want somebody to listen to what I have to say. And that's part of there used to be death panels and a lot of fear in policy and politics. And I think a lot of that has subsided. There's bipartisan support for this, for funding. Dr. Atul Gawande's book, Being Mortal, came out and is an international bestseller in many languages. So I think there's also just been kind of a cultural shift, celebrities talking about their experiences, normalizing this, caregivers sharing their life on social media, where people realize oh, I can do this too.
Absolutely. With 10,000 people turning 65 every single day and the sandwich generation picking up the slack in many instances, and those messengers, as you refer to them, are increasingly important. Do you find that they're actually encouraging their parents to go through the process, or that they're more interested about themselves in case something happens to them?
I'm going to say yes to all of the above. There's people who are realizing, I'm really worried about a particular parent. That's why I'm coming to the website, or that's the conversation I'm interested in having. And we try to then help convert them to say yeah, and you. Or one of the easiest ways to break the ice and bring it up with somebody else is, hey, I've been doing this myself. And it made me realize, like, I'm not so sure I know what you would want in this situation. There's a lot more language that we've included. It's really meant to be about honor and respect. And uh, this is, again, assuming the relationship is a good one, which we also know is not always the case. And we can talk about that later as well. But the ways of introducing this that don't come across as negative, but really as like a loving opportunity, I think have helped a lot as well.
Let's talk about some of those methodologies, the tools, the resources that you're helping family begin those discussions with. Can you walk us through some of them and explain how they're designed to help people and where people can find them?
Yeah. So if you're watching this, you'll see me holding up a little guide right now. It's just a small little booklet. We have topics on how to have conversations, how to choose a healthcare proxy, how to talk to a healthcare team, a workbook for somebody living with a serious illness who maybe never wants to hear the phrase end of life or death, but they have a serious illness and you want them to start thinking about things. These are all free tools that we've created. They're multiple languages. They can be downloaded from the website or, printed off, distributed. And they're really meant to help walk people through what your values are, not asking people to think about a lot of medical, hypothetical scenarios that could play out. There's no way to discuss every hypothetical scenario that could happen in life. And that's maybe what holds people up, or they think I'm not a clinician. I don't know all the difference between feeding tubes and CPR. But we guide people through questions about what matters most to you and what would you want somebody to know if there were a time that you couldn't speak for yourself. And this is one reason why I think a lot of other people have gotten involved. It's not always an end of life scenario. It could be there's an accident or you have to go into surgery or you're unconscious for a day or two, but somebody's got to make some decisions about what you'd want and you're going to be fine later on. So I think that's helped people realize this could apply to them. And so we're asking people to think about what are your values? How much do you want other people to be involved? Like those are the things you can discuss. So I think about a colleague of mine who had this conversation with her husband and they've got 2 kids and parenting is a really important part of her answer where she says, if something unexpected happened to me, I'd want you to think about the prognosis. And really, if I can intellectually and emotionally parent our children, I'm in. I'd want you to do whatever it takes. I don't care about physical limitations. If I can talk to them about their day, understand what's going on, hear about their social issues, and really help in that way, I would want you to do whatever you can. But if I couldn't participate in their life in that way, I don't need you to take extreme measures. That's an example that really captures almost every scenario that could play out. And her husband is able to think, if asked by a doctor, what should we do in this situation? All right, well, now talk to me about her prognosis. How would this go? And so people have all different, there's no right or wrong answer. I want to be really clear about that. We have no preference for the type of care somebody would want. We've seen couples where one person is like, if I'm blinking, I'm in there trying to come out and new science may come out, like cryogenically freeze me because I want you to do everything. Married to somebody who's like, oh, no, absolutely not. Like I've done enough. I don't need you to do a single thing. I'm good to go. It's important. If you've got different opinions, how can you find somebody that could honor your wishes, or what could you talk about to make it easier for them to understand, oh, this, Mom and I talked about this. Here's what she told me.
And that's one of the most important things to frame is that you need to communicate so someone can act based on your wishes and not step in and act with what they want to have happen to you. So there is legal ramifications as well. And oftentimes people talk about advanced directives. Has that come into play in the sense that we've been talking now for almost 10 minutes, a little bit over that actually, and we haven't said advanced directives yet. Instead, it's the conversation, it's making sure that you're heard and listened to. Is there a specific reason why you haven't used the term yet that is the legal side of things, or is that just purposue and known?
It doesn't happen to be the focus of what we are centered on, and I still think it's a really important part of advanced care planning. So I see the Conversation Project as an addition to almost every advanced care planning entity that's out there. If you're doing an advanced directive, or I don't know if you guys have talked about POLST or MOLST forms before, or doing legal or financial planning or burial plan, whatever the thing is, the Conversation Project is meant to be a resource for how do you talk about it? Because we know it does not do us much good if somebody does all of their advanced care planning and they file something away and they've chosen a healthcare proxy and they've never told that person that they chose them. They've never talked about what they wanted. And then a family 6 months after the lawsuit, somebody finds a manila folder in a desk that's like, whoa, we did the wrong thing. Or my favorite, somebody's like, oh yeah, I did that. It's in a safety deposit box,
Yeah.
but like nobody's talked about it. So for us, I think the documentation is a very important part. So I'm not a lawyer. I'm not going to say that it isn't. I know that a lot of clinicians say they would rather have a family come in who's on the same page without a legal document than somebody who swoops in and is like 13-year-old document here that says the opposite of what you're saying mom told you. And so it's like, how do we get everybody who might have a say or think they have a say on the same page? And I do think the documents are really important. We've seen a really growing segment of solo agers, people who don't feel that they have a natural proxy in place, or they don't have a spouse or children or family. And it's really important to have legal documentation on file with all the different providers. And it's really important if there's somebody you specifically do not want involved in your care, and to make that known. And we know that not everybody has a great relationship with their family of origin for whatever reason that may be, or a particular person they don't want involved. So I'm never going to be against advance directives. I just don't think that they are worth as much if nobody's able to talk about what's in there.
Yeah, they're certainly complementary, and there's so many parallels to the other conversations on the other podcasts that we've had as well. And for us, we've got the Clear Kit, which helps people organize their information. And literally, one of the first steps that you have to do is tell your family members or your loved ones or people that will be impacted that it exists. Because if you have the conversation or you have the documents and people don't know about it, it's the equivalent of them not existing at all, for all intents and purposes. Now, you spoke to single agers, and this is something that is becoming more and more and more important for a variety of reasons. Not only are the people that are single in their own right, women are outliving men in the country by an average of 5.8 years when they're married. Aging demographics, 10,000 people every day turn 65. What are some of the common challenges or barriers that single agers and others are facing when they're trying to start these conversations, and what can they do to overcome them?
Some of it is giving permission to folks to think outside of the tradition of spouse or child, and that there could be a friend. I remember speaking at an event, and a woman came up to me and she's like, my husband died recently. We didn't have children. I have a niece who lives on the other side of the country I'm not super close with, who I've chosen, but my neighbor is one of my best friends. Like, we go on a cruise together every year, and I really trust her judgment. Are you saying that I can choose? It doesn't have to be family, and I can choose this other person who I might be close to in life. So some of that is like broadening the scope of who might be a proxy. And I say proxy here in some states as agent or surrogate, decision maker. There's different terms, but that person you would choose to speak on your behalf medically. So sometimes it's that. Other times it's looking within the community. In some states, you can hire somebody to play that role, or there's aging resources in a community that could help. We've seen a lot of community groups start pairing people. So I remember there's a congregation we worked with in Boston who realized they were doing advanced care planning, which is a whole other interesting thing of how denominations and congregations can help give permission. I remember somebody's sermon was, y'all want to go to heaven, but nobody wants to die to get there. Like, we need to, like, we spend so much time talking about this, and now we need to address this. And here's places in the Bible or the Torah or other, all different denominations where you have permission to talk about this. And so there was the congregation that found two people who really were solo and didn't have anybody other than within their congregation who could help them. And so they paired them together and said, could you guys be each other's healthcare proxy? But if we put you together, and we'll help foster the conversation so you can each understand what the other person would want. And that's been an amazing resource. So I think it's getting a little bit creative about who else might be out there who could play this role, and getting that legal documentation or the medical documentation on file, making sure that all your providers, health system know that.
You guys should start the Conversation Proxy Match Project,
Oh, like put people together with each other?
Like, it's Bumble and OkCupid and everything for people that are aging, connecting, and location and interests. And next thing you know, you swiped right. And
I'm going to put that, rubber that you've got the business, you've got all the things, that one can be yours. But it is interesting to see like Facebook groups for solo agers with 8,000 people in it, and folks who are really connecting over this status and making friends and relationships in that way. And so again, helping people realize like that can be who you choose.
Unbelievable. We're focused primarily right now on the conversation on individuals. I know that it isn't the primary focus of the Conversation Project to work with the healthcare providers themselves, but I'm sure that you have lessons, takeaways from that realm. Can you talk to that a little bit?
Yeah, we've done a lot, and especially because of our parent organization, IHI, we've done a lot of work with healthcare systems. And so for those of you who might be listening who are interested in that, we've got white papers, we've got how to talk to patient type things, but we've done a lot of work. If I do my job and more people are having these conversations and show up activated and knowing what they want, it doesn't do much good if the other side of that helix, the healthcare system, is not receiving it correctly, or it can almost cause more harm by having somebody say, like, I know what my dad wanted and we still didn't get that done.
Mhm.
And so we've got a lot of work with healthcare systems of how do you reliably receive, record, respect to somebody's wishes. And I think that goes everything from how to exemplify this work yourself. A lot of clinicians haven't had these conversations, and there's a lot of work health systems are doing. I remember somebody in Memphis saying, we've got 10,000 hospital employees in the city. If each of us had the conversation and chose our proxy and modeled the behavior in our community, this can help snowball out. Or a large hospice group in Louisville, Kentucky, who was, sampling with their staff, and they realized that only half of their employees had done this, even though they realized how important it was with their clients. And it was a lot of the non-clinical staff didn't think it applied to them. They thought only doctors and nurses could do it. So there's a lot we can do to even it's a lot easier to talk to a patient if you can walk the walk and say, I know this may feel uncomfortable, but when I talked about it with my parents, here's how it went. There's a lot that can be done to connect in a way that is culturally appropriate and with humility and curiosity for who the patient is that you're working with or the family you're working with, and to not assume that what you would want in this situation is what they would want. So there's a lot of work healthcare systems have been doing on that. There's a really neat project at Stanford University on ethnogeriatrics, where they look at the 14 largest kind of ethnic groups within the US and how do they approach death and dying and what can you learn. It's like a little course, if you will, on understanding different demographics. And especially with language translations, that's been an important. I remember a health system in California that did a lot of work to train their staff on how to have these conversations. And they got right into the first day of trying to roll it out and had not accounted for the fact that 40% of their patients were not English speaking and the interpreters had not been trained. And so they were suddenly, the interpreter's like, I can't say that. I don't know how to do it. Or like, this is so uncomfortable for me. So really thinking about how to connect with whoever the demographics are. And how to just start bringing it up in a way that doesn't set off alarm bells for people.
Mhm.
If this is something that every provider, it's like, I do this with all my patients, Mrs. Jones. I'm not bringing this up because it's not like, oh, doc, what are you telling me? Are you telling me there's bad news? It's like, oh no, we do this with everybody at their first Medicare intake form, or immediately upon this kind of a diagnosis, this is what we start to talk about. So we don't have to deal with this later. Like, let's start normalizing it. Or you move into a retirement community. This is just what we do with everybody. And then I think it's so important. Sorry, I've got a lot of thoughts on this. But
No, I love it.
how do we steward this information? We often use the analogy of as reliably as we do allergy information, that in a healthcare system, how inappropriate it would be of like, do you have an allergy? Yes, no, and no additional information. And yet we often ask, do you have a healthcare proxy? Yes, no.
And that's it.
If somebody says no, there's not always follow-up. Or if they say yes, like, do we have it? Or did that follow the patient from the emergency room to the floor? Or new staff, a shift changeover that happened? How can we work, especially with electronic medical systems, to make this information easy to find
Mhm.
and to acknowledge that people's wishes can change, and that like, oh, that's an old file, there's an updated one. I remember a physician in Boston was talking about a patient who was like late 80s, early 90s, had a lot of health issues. He had been very clear he did not want extreme measures taken. And yet he was admitted to the hospital, ICU, full code status. Like, it was the exact opposite of what he'd always said he wanted. And his doctor was rounding and was like, what's going on, Mr. Brown? Like, I thought we had a plan. He's like, we do, but my first great grandchild is due in 2 weeks. And I will do anything I can to be here to meet that baby. And then we can go back to the old plan. And that example to me is what's so important, that the healthcare system isn't like, well, one time you filed this document and that's the only one we have on file. So how do we steward that? And that's all in service of how we can respect somebody's wishes. And so I think we have a ways to go. And yet I'm encouraged to see how many more medical schools, nursing schools are even addressing this, how many more oncologists and cardiologists are open to this. They've often been in the business of I'm in the business of hope. I can't take that away from my patients, and realizing that this is something that can go hand in hand. And it's really about what matters most to you. And we can make all of our medical decisions based on that.
Absolutely. You've evolved over time. There's so many different opportunities that you just brought up. The landscape is quite diverse, both with opportunities, with those who need it in different segments. What's next for the Conversation Project?
There's a lot of things that are on my wish list. I mean, we're nonprofit. Everything is free. So
Hmm.
some of my what's next is always seeking out new funding. We're all philanthropically supported by foundations. So we're always grateful for that. And that's helped us keep going. The thing that I'm particularly interested in, and some of the funders have been interested in, is this idea of messengers and how are we getting, especially if we talk about cultural differences or equity, I want to be careful that we are not furthering divides in care. That we know that historically it's been more white, upper middle class people who have these conversations, who honestly even expect the healthcare system to listen to what they want. Like, I have an opinion and you, Mr. Doctor or Mrs. Doctor, are going to listen to what I have to say. Like, that's not a universal experience. The experience of going to a healthcare system is not always universal. And so how do we not create further inequities of who gets to have a good death? And so thinking about who are better messengers on this. For some people, it's not the healthcare system. That's not who they would trust to be bringing up this topic. And maybe it's faith communities or the world of social media. It's just, I think it's amazing. I know there's a lot of criticism of social media, but if you take Instagram, for example, to see people who are sharing their caregiving experience or these really niche topics of somebody who's a caregiver for a skip generation. Like, I'm a Gen Z caring for a grandparent who has dementia, and I'll share with you my day, and the hundreds of thousands of followers of people in similar boat. If we can try to find more of those people to help be messengers around normalizing these conversations, that's something that I'm particularly interested in. And rather than people always hearing from us, like, how do we find guest bloggers or people just sharing their examples and their stories? So that's what I'm excited about finding more of.
What's one question that you wish people asked you more of?
About the Conversation Project?
Yeah, it's a tough question.
I know. I wish people would. I know measurement is super important. And I feel like my senior sponsors at IHI would be mad at me saying something against measurement. But I feel so clearly, and we get examples from people about how important this work has been for them, or how these conversations have really changed the trajectory of somebody in their life's care. And it's really hard to measure. And so when people say, well, how many conversations have been had? I can't count conversations had. And so trying to think about, like, what are some other interesting ways to measure the effect of this work when somebody might have a conversation today because you've now just heard this great episode and you feel like, oh yeah, I can do this. And hopefully we're getting to normalize this so much early on that the end of life for somebody is not going to be for years. And so we can't count the change there. And so when especially when you're grant funded or you're trying to show the value of your initiative, I think that's where I often get stuck between, I don't want to only focus on people who are really sick or really old. And those are because we could count those deaths, and we could show that if you had this conversation, here's where it made a difference. I really care a lot about moving this upstream and just normalizing it for people, especially, this is kind of a new topic because science and medicine and technology have gotten so advanced that we can actually make decisions. That isn't always the case. That's not the case all around the world. And so I think that's one area that I feel kind of passionate about, or wish we could creatively think about a little bit more together.
Yeah, you should go back to the board and the funders and talk about the gross national happiness quotient. Are you familiar with it?
I've heard a little bit about it, but I'd love to hear how you think it applies here.
Yeah, it's a philosophy and index in Bhutan that measures the well-being and happiness. So it's not a metric of XYZ, we've done this, but rather you can apply that type of framework of this conversation has the ripple effects that makes other people's lives better. And it's not about right now, but the effect of later on down the road, if we do this, how is it going to impact everybody's well-being? Because having conversations in place, as you've said, as you've seen, as people have come to you to share, it's just so unbelievably important.
Well, we have seen some around depression rates, that for people after the loss of somebody in their life 6 months later, if they had these conversations, their depression rates are lower. And so that's really what I'm drawn to for this work, is not only the person whose end of life we might be discussing, but that ripple effect of family, friends, other people who, again, this idea of how complex or complicated the grief can be. Like, are siblings still talking to each other? Are people feeling a lot of second guessing? Did I do the right thing?
Mhm.
I care a lot about that layer out. So I like your point of happiness or less depression or whatever that might be of the experience for people.
If people are interested in learning a little bit more about the Conversation Project or getting in touch with you, how do they do that?
Yeah, you can check out conversationproject.org. Everything we have there is free and available. Would love your feedback or advice. All of the guides we've created are based on what people have asked us for. So we've got a pediatric guide, but that's because people started to ask for it, or languages they wanted. That's what we've, it's been responsive to that. So please reach out to us or follow us on social media and tell us if there's people you think that we should start engaging.
All right. Kate, thank you so much for sharing your insights and the incredible work that you and the team are doing at the Conversation Project. We appreciate the time.
Thank you.
Thanks for listening to another episode of the Buried in Work podcast. Remember, you can save 10% on our estate preparation package and games with code podcast10 at buriedinwork.com.